Go ahead and get started. Welcome, everyone. Thank you for joining us. Today is our special Grand Rounds Day, which you know that we use.
Articles and trials and kind of try to quantify and try to give more details on 72 hours fast. And so he is definitely a grandfather of hypoglycemia. And so this slide kind of, I took it from one of his articles that shows that depending on, we all know that on hypoglycemia levels, we will have first autonomic response with release of glucagon, epinephrine, growth hormone, and that will lead to your typical symptoms of hypoglycemia. And classically, we used to kind of differentiate hypoglycemia with and without symptoms. Later in my presentation, I'm going to show that the symptoms may not always correlate well with level of hypoglycemia, but we got to know the classics before getting into more details. And we kind of know, so once the blood sugar gets below 50 or 45, classically, that's where patients would present with more neuroglycopenic symptoms. All right, very good. So there are different ways how all hypoglycemia can be kind of divided and classified. And one of the practical approach would be to divide hypoglycemia in critically ill hospitalized patients versus hypoglycemic patients that would present in the clinic setting. So a typical hospital presentation in critically ill patients would be the typical causes, obviously, insulin or sulfonylureas, alcohol, medications, obviously hypoglycemia of critical illness, renal failure, sepsis, malnutrition, hormone deficiencies. In the outpatient setting, we think of insulinoma. Again, those are interchangeable. Most true insulinoma patients that I've seen in my career, they presented from the hospital, but that's kind of they typically have less acute presentation. Obviously, in this category, the post-bariatric and reactive hypoglycemia, as well as autoimmune hypoglycemia, and obviously incidental or malicious hypoglycemia. All right, very good. So just kind of briefly show the slide that covers all different medications that are non-insulin mediators, non-diabetic medications that may be associated with hypoglycemia. A list of vary, but the only more or less strong evidence would be quinolone and indomethacin, so as the glucagon after endoscopy. So the ACE inhibitor and beta blockers and things like that listed, but they truly rarely occur, and they're more case reports. But at least in the differential diagnosis, we'll always cover that. Okay, very good. So we're gonna move on to the hypoglycemia workup. So we all aware of the typical diagnostic algorithm that obviously most places will have some kind of protocol for either 72 hours fast or someone who is for the outpatient that will start the workup. We would get insulin, C-peptide, proinsulin, beta-hydroxybutyrate, sulfonylurea screen with plasma glucose when blood sugar below 55, and depending on circumstances, patients will get glucagon. So traditionally, again, so this hypoglycemia workup, we divide it into fasting and postprandial. Again, this classic approach, as I will show later in my presentation, kind of will fade away in the future, I believe. But the one that stands for fasting hypoglycemia, and that's what we kind of start to talk about, is insulin-mediated hypoglycemia, obvious exogenous or sulfonylurea, insulinoma or insulin antibodies. For the low insulin level, when patients will have elevated beta-hydroxybutyrate and glycogen, decreased glycogen storage, so those would be ketotic exercise. Among those that I will kind of cover in a couple more slides will be glycogen storage disease, alcohol use, and obviously acute illness as well. All right, so let's go ahead and talk about insulin-mediated hypoglycemia, since this is the holy grail of the whole hypoglycemia, and every hypoglycemic patients that we ever see deserves at least a thought of having insulinoma, right? So that's something that we always roll out. So this, I have just one slide dedicated specifically to insulinoma. It's very, very rare. 10% malignant, can be multiple, can be associated with MEN1, and manifest in the 5th decade in female, and obviously, so those are kind of common things, okay? So the less common causes and kind of a little bit more confusing insulin-mediated hypoglycemias are the autoimmune kind, okay? So there are two different autoimmune kinds. Benign insulin autoimmune syndrome, that's the one that's associated with high insulin antibodies. It is very, very prevalent in Asian population, and it's extremely uncommon in non-Asian population. Generally, it's benign. Rarely does it lead to any major medical issues, and So rarely it kind of anything other than differential diagnosis, and rarely causes severe hypoglycemia. So the one that is very, very challenging and very, very scary diagnosis, and I did have a patient with type 2 insulin resistance. Those patients make insulin receptor antibody. So it's antibody to insulin receptor. Those patients present kind of sort of like our insulin resistant kind. So they will have acanthosis, women will have hyperandrogenism, and they typically coexist with autoimmune conditions. The ones that I have, the patient that I've had, the patient had prior history of Graves' disease, and lupus and Graves are the one common association with insulin receptor antibody disease. So the challenge with the type B insulin resistance, those patients will have fluctuating blood sugar level. When the antibody titer is higher, they will have higher blood glucose, and when they will have low titer associated with low glucose. The biggest challenge, if we think about it, this insulin receptor assay is commercially not available. The patient that I've had, we ended up getting him enrolled in a clinical research trial, and we were able to demonstrate his insulin receptor antibody. Generally, those patients will have very poor prognosis, high mortality, and unfortunately, that's what happened to the patient that I have. Treatment, we don't have any successful treatment modalities, different immunosuppressant use, as well as steroids, but generally it's very challenging condition, likely very, very rare. Okay, so we're gonna go ahead and move on to the second column of fasting hypoglycemia that is non-insulin mediated. Again, I'm not going to cover common conditions that we see frequently in the hospital consult, but the ones that I would like to highlight would be glycogen storage disease. Typically presents in kids, and pediatric colleagues typically diagnose those, but type 1, type 3, and this lack of glycogen synthase can present in adulthood as well. And I also did have a patient who ended up sending for genetic testing to further uncover this condition. So out of different glycogen storage disease, type 1 is the most common, again, generally pretty rare, can present in adults with hypoglycemia, lactic acidosis, hyperuricemia, high triglycerides, and hepatomegaly. And the only treatment modality is frequent feeding and with complex carbs. Those patients are not extremely sick, but they do need a lot of care, counseling, and education. All right, so, and one of the kind of another in that class of non-insulin mediated fasting would be fatty acid oxidation. I've never had that, but it is autosomal recessive. Can again typically diagnosed in kids, but those kids can graduate to the adult world, and those patients should avoid fasting and a high carbs diet, and they typically managed by a genetic specialist. All right, so so the next slide is, yes, we have seen a lot of the alcohol-induced hypoglycemia. A couple things about it, since it can be quite challenging and hard to point out. Alcohol can inhibit gluconeogenesis, but not glucogenolysis. The typical pattern that those patients present, they will have several days binging, and then subsequently they will have a hepatic glycogen depletion, typically would be your 48 hours, with obviously in addition to limited food injection. A lot of the patients, they present with with this kind of hypoglycemia, by the time they're in the emergency room, their alcohol level may be undetectable. And that's something to put on the differential diagnosis if we're seeing that hypoglycemia in the emergency room. All right, very good. So the next kind of rare cause, but that's something that I personally have to admit, I have to look up and kind of find the right testing, because that's pretty confusing. Again, those patients exist with non-islet cell tumors, right? So those tumors typically large. They're typically of mesenchymal origin, and those tumors will produce IGF-2, which can activate insulin receptors. To diagnose non-islet cell induced hypoglycemia, IGF-2 to IGF ratio would be measured. It literally takes 2 to 3 weeks to get the result back. Obviously treatment is a surgical excision, and different tumors, including mesothelioma, fibrosarcoma, and medullary thyroid cancer, as well as carcinoid, as well as ACC, can potentially be a source of excessive IGF-2 production. All right, very good. So we're going to go ahead and move on to a second part of the hypoglycemic table and talk about postprandial hypoglycemia. That's kind of the biggest challenge, but also my biggest passion. And I think that's the hypoglycemia that needs more attention and more research and more of everything. Postprandial hypoglycemia, again, classically defined as the one that occurs up to 5 hours after a meal. Typically, those patients will start with blood glucose testing, followed by possible OGTT, which I will talk about that in a minute, a mixed meal test, and obviously continuous glucose monitor. In those category, post-bariatric and reactive hypoglycemias are most common. Again, some patients that have fasting hypoglycemia, they will have, those are very, very soft division between fasting and postprandial. Okay, so very good. So again, this is a very old study that will kind of demonstrate the utilization of a different diagnostic tool for postprandial hypoglycemia. This is a nice slide that basically enrolled 650 patients, 650 healthy volunteers who have had oral glucose tolerance test, and this showed that 10% patients had postprandial glucose level below 47 without association symptoms. And based on this article from 1981, we stopped using OGTT for diagnosis of hypoglycemia, and that's where mixed meal test became a preferred diagnostic tool. So I always kind of felt that mixed meal test is a little bit of the kind of a enigma. Different institutions have different protocols and different articles will report different foods or different liquids utilized. At IU, this is kind of typical when someone, that's one of the sample meals that I just showed. Patients bring with them to the clinic their 50-gram carbs meal, or they can bring the boost. And this is an example when they bring 1 egg, orange juice, milk, and oatmeal. When they show up at the clinic, they get their fasting blood glucose, insulin, and C-peptide checked. They're supposed to eat their meal within 10 minutes, and then their labs are being drawn every 1 hour for 5 hours. The duration of test is pretty standard. The meal composition can vary. All right, very good. So, this is I really like this article that demonstrated the usefulness of a mixed meal test comparing to oral glucose. This is a very, very small study when they had 26 patients with who had symptoms suggestive of postprandial hypoglycemia. And all patients first had oral glucose tolerance test. That's the one that has filled the black dot. So out of this 26 study patients, 9 patients had symptomatic hypoglycemia during OGTT, and they did have associated symptoms, and they did have blood glucose. They use a cutoff for 50. When the same patients had mixed meal tolerance test, none of the patients had hypoglycemia in this study. They used cutoff of 70, and 2 patients did complain of being weak and shaky. So that's kind of a first study that kind of tried to introduce the idea of there is a little bit more to the story that than the hypoglycemia with symptoms or without. So my next slide is going to kind of, it's more modern study when they compared oral glucose tolerance with mixed meal test. And they mostly focused their report on the symptoms. They've had a study group of 40 patients. They were non-diabetic who've had reactive hypoglycemia symptoms, and the control group was kind of normal volunteers. So both groups had HOMA-IR. They had 75 grams OGTT, and a study group had mixed meal tolerance test. So the result of the study group demonstrated that 12 patients, that is 30%, had hypoglycemic symptoms when their blood sugar was below 55. In the same group, 25% patients had symptoms without hypoglycemia. Again, the utilization of mixed meal test, 43% patients thought that they're hypoglycemic, but none of them had blood glucose below 55, okay? So that was a very, very nice study, kind of changing our paradigm and classic approach of hypoglycemia with symptoms versus hypoglycemia without symptoms. All right, very good. So obviously with the new technology and the new world, we've been using a lot more continuous glucose monitor for those patients. And as we know, the CGMs were designed for diabetic patients. They are still not FDA approved for hypoglycemia. Obviously, the use for hypoglycemia is off-label. That's where a lot of insurance coverage challenges will meet. This is probably my favorite slide of the entire presentation. This study had 153 participants, and they're multi-center. They were in different. Then they're all done in the U.S. So participants were on Dexcom CGM for 10 days, and they reported that median time spent in glucose below 70 was 1.1%. Okay, they did their very, very sophisticated calculations model, and the authors of this group advocated to use CGM value of 54, which represent a lot more meaningful cutoff for for hypoglycemia rather than 70. As there is a large number of patients who did have blood sugar level ranging from 55 to 69. I believe, Dr. Shah, he recently joined our IU department. So he shared that they advocated with ADA, so as the FDA, so as with the Dexcom, to try to change the hypoglycemia cutoff. So I think it's still in the works. One of the things that they're really trying to push is to allow the Dexcom alarm and a Dexcom threshold go below 70. And obviously that still is not happening, and it would definitely be difficult to justify as we use different blood sugar levels and thresholds for diabetic versus non-diabetics. All right, very good. So we're going to go on and move on and talk about post-bariatric hypoglycemia. So that's the one that a little bit better studied and a little bit better represented and better written. So the typical kind of proposed mechanism is the increased action of GLP-1 that leads to postprandial hyperinsulinemia. And along the line, those patients would have reduced glucagon and increased glucose sensitivity. And obviously there is a lot of research that are going on in the gut microbiome, and that may potentially be one of the factors. Okay, again, so this is the same study that kind of demonstrated basically that and again, they utilized mixed meal test as a better test for diagnosing postprandial hypoglycemia. This study had 65 patients with a gastric bypass, and they compared those patients with a BMI matched non-surgical patients. And they demonstrated that in post-bariatric hypoglycemia, we will see elevated insulin level as a result of elevated GLP-1 level, GLP-1 leading to increased insulin level. Okay, so that's kind of another study showing hypoglycemic pattern in post-bariatric patients, and this is a little bit more cumbersome study when they had several groups. They've had post-bariatric patients. They had a non-surgical reactive hypoglycemia, and they compared those to pre-diabetic, new diabetic, and healthy control. In that study, they were not able to use the G6, they used the G4, Dexcom. And their conclusion was that post-bariatric patient had highest glycemic variability, and lowest blood glucose level was twice higher comparing to control. And the most important piece of information that I got for myself from this slide is majority of those hypoglycemic events below 70 occurred at night. Same observation they made for a non-surgical reactive hypoglycemia. Those patients had 4-fold increase in hypoglycemia below 70, and that was still predominantly at night. So there comes our classic postprandial hypoglycemia classification. Again, that's kind of part of the previous study. I just showed that in this patient with non-surgical hypoglycemia, comparing to post-bariatric hypoglycemia, glycemic variability was normal. And again, the only pattern that stood out and was statistically significant is that non-surgical hypoglycemic patients had hypoglycemic nighttime fasting blood sugar pattern. All right, very good. So that's kind of one more study on post-bariatric hypoglycemia when it's, again, multi-analysis that compared Roe and Y comparing to sleeve gastrectomy. And again, there is significant nocturnal hypoglycemic pattern was reported in this meta-analysis, and the authors of the study concluded that time elapsed from the surgical intervention positively associated with higher risk of hypoglycemia. That is, the farther someone from the surgery, the higher the risk of hypoglycemia. And again, not only daytime, but nighttime. Okay, very good. So this just study, I was not aware, I've never seen this study before, but as I was preparing to this presentation, I found this is very intriguing study that I wanted to share with the group. This came from Japan when they've had 34 male participants and those who were in Medtronic's CGM. And they demonstrated that patients who've had higher rate and higher occurrence of hypoglycemia below 70, those patients were more likely to like to snack, and those patients were likely to have higher BMI. And those patients, they kind of concluded in that study that if you snack more than 5 times a day, that can lead to ongoing weight gain, but they kind of tied it up to a reactive subclinical hypoglycemia occurrence. So I found that's very intriguing, and obviously ruins a lot of dietitian advices on small frequent meals. All right, so moving on to a last part of my presentation on hypoglycemia treatment. Obviously, we all know the immediate treatment with 15 to 20 grams of carbs and recheck. And so the only interesting part of the acute hypoglycemia treatment is the recent evolution of glucagon preparations. Obviously, for years and years and years, we have our red glucagon red glucagon kit. In the last 5 years, we have number of more user-friendly product. Obviously, as we know, they're pretty costly, and not all insurance covers. And I still have patients complaining that they find Baqsimi confusing. So, and I've had a number of patients who just say, "Okay, give me the old glucagon kit. That works. I know how to work that one." All right, very good. So that's a kind of a summary of post-bariatric hypoglycemia treatment, and most of the information on this slide on post-bariatric hypoglycemia treatment can be kind of extrapolated into reactive hypoglycemia. So obviously, a lot of the education that we'll put in, you do need to have a good nutritionist or diabetic educator who will talk to patients about tests. So typically start with blood sugar testing and keeping the food diary, educate about complex carbohydrates, balanced meals, and all the things that kind of easier said than done. Then patients will need to get educated on acute hypoglycemia treatment. Our medical tools box is very, very small, and options are extremely limited. So the only FDA-approved option for post-bariatric hypoglycemia presently is diazoxide. I don't know if you guys have used it before. I used it. That's a medication that extremely difficult to get. It needs to be ordered, pre-ordered, and measured in the liquid, associated with a lot of fluid retention in addition to the weight gain. So definitely a very, very suboptimal tool. For the off-label, obviously, I'm sure you guys used acarbose. It's got a bunch of GI side effects. Most patients cannot stick to it. I have only a few number of patients who can stay on it. Octreotide, we frequently use in the hospital if needed. On the outpatient, it's again quite challenging due to the cost and again insurance coverage. For post-bariatric patient, obviously our last resort is reversal of surgery, and I have seen one patient who had to have a feeding tube, and I did see a reversal, which actually reversal did not fix hypoglycemia in that patient, and she still was pretty miserable. Again, additional off-label use that was not in this graph that I pulled out of JCM. We do use occasionally calcium channel blocker, obviously metformin or vitamin M, and I have a couple more slides dedicated to GLP-1 controversies. All right, very good. So the classic approach, as I showed in the earlier study, that the classic approach is that GLP, once it connects to GLP receptor agonist, it will cause insulin release, insulin secretion. So therefore, the utilization of GLP receptor antagonist would physiologically make most sense for treatment of hypoglycemia. So the medication named avexitide is a GLP-1 receptor antagonist that was first reported and technically FDA approved for post-bariatric hypoglycemia in 2021. And the only trial that's available and published is phase 2 trial, when they used lower dose of this avexitide, and they successfully demonstrated increasing nadir and lowest insulin peak. And they were able to demonstrate that 50 to 75% patients did not require rescue treatment. This medication was well tolerated. I was not able to find much of the good explanation for what's holding kind of and from to make it to the next level. There is a phase 2B clinical trial that uses higher dose of the avexitide, of the GLP receptor antagonist, and that, at least from what I can tell, is ongoing. And there is also phase 3 trial, but it's still in the works. They're still, I believe, recruiting. So therefore, this medication is not commercially available, and I don't have a good insight on when, if it will be available for our use. Okay, so oh, sure, you can go ahead. Okay, someone, okay, that's fine. Okay, so in kind of into to take it, oh, your slide is, okay, let me go and make sure, okay. Okay, So this is a study that is completely counterintuitive and completely opposite to what I just showed. This is a small study. This is a meta-analysis of several small studies that were put together. But the authors demonstrated that GLP receptor agonist, as we know in our clinical practice that we use for type 2 diabetics, generally do not cause hypoglycemia. So this study, and I'll show you the graph on the next page, suggested that GLP receptor agonist can reduce number of postprandial hypoglycemic episode and improve glycemic variability. So this is again the summary of this prior meta-analysis that they've had very small number of patients varying from 1 case report up to 11. But every study included in this chart showed very positive outcomes using different GLP-1. And presently, I'm working with my fellow, and we're also trying to put together a case series of GLP use in post-bariatric hypoglycemia. So far, we have 5 patients that had very good positive outcomes, and I'm sure there are a lot more information or a lot more off-label use of GLP-1 in post-bariatric patients that are used, and that definitely something that deserves more attention and kind of goes a little bit in contradiction with our classic approach. Again, so it can be all tied up to this snacking, the Japanese study that I showed, the vicious cycle with frequent meals, and by mechanism of possibly weight loss, appetite regulation, improved insulin sensitivity. It may be effective. So to conclude my presentation, be aware of rare causes of hypoglycemia, including autoimmune, non-islet cell. So the most important portion of my presentation is to emphasize importance of appropriate blood glucose cutoff of 54 rather than 50 when diagnosing non-diabetic hypoglycemia patients. There is still more research and there is a lot more information needed until that makes into more standard of care. Post-bariatric hypoglycemia, not always postprandial. So as several studies demonstrated, a lot of the times it can be nocturnal, and it still remains a major diagnostic and clinical challenge. Again, reactive hypoglycemia remains poorly understood and understudied, and I do advise extreme caution when we put the CGMs on those patients, because typically it's a lot more anxiety provoking and a lot more challenging for patients and for the provider to kind of further untie all this hypoglycemia. And GLP-1 can be a pathway that has promising therapeutic venues. All right, very good. Well, that's all I've got on my presentation, and I'll be happy to answer questions.
Thank you. That was great. And those of you who have questions, you can put it in the chat box or unmute yourself to ask the question. So while you guys are thinking, I'm going to start off with a couple of questions, if you don't mind.
Sure.
So the old, the thought about not using GLP-1 agonists is that post-bariatric surgery, there is increase in natural GLP-1. Using the GLP-1 agonist, that's why it was not really thought of. Actually, there were a couple of studies way before, and then people switched over to GLP-1 antagonists. From your study or the studies that the meta-analysis, was there ever a measurement of GLP-1 level and using that as a guide to do that?
I don't think so.
Part of it. Okay.
Yeah,
So
I did look into it, and as you know, it's not readily available. It's mostly basic research tool, and those may mostly kind of more case report observational studies.
And the other part of the same question is that, is there any evidence that the GLP-1 agonists work based on the time from bariatric surgery? So this, at least the studies that show increase in GLP-1 were early on until in the post-bariatric surgery. So is it, if the hypoglycemia is occurring, a little bit time away from the, I don't know, I cannot even think of what duration that might be, GLP-1 antagonists versus that. So because, they're so counterintuitive, like to use either one, this avexitide, I think one of the centers was in Madison. We used to try to send patients there. Dr. Davis, who is actually last author, she gave us a talk a couple of years ago in our diabetes symposium. So, it's kind of really counterintuitive. So I wonder if there is any relationship, the duration from the time of surgery when this type of which drug would work. So I don't know. I'm sure there's not much data. So just your take on it.
Yeah, that's definitely a great thought. The typical traditional onset of classic post-bariatric hypoglycemia is 3 to 5 years. That's kind of averaged. And obviously excluding dumping syndrome. So it's a great thought. I don't think it would require longitudinal years trial to kind of try to figure out if there is such pattern. Definitely great thought. I'm sure that would require large financial commitment to kind of be able to follow those studies, follow those patients long enough. I don't think there is a good pre-operative predictive tool which patients are at risk of hypoglycemia. So obviously if there is such tool, then that would have been kind of a little bit easier to follow those patients over time. But yeah, those are great thoughts.
Thank you. I think Dr. Carroll has a question. Ty, you want to mute yourself?
Hi, Alina, nice talk. Thanks for giving that on a really tough subject. So the question that I have, which probably doesn't have a great answer, but for all of us who see these patients in clinic with quote unquote spells or hypoglycemia, or I have a history of hypoglycemia with these symptoms, and I think we all see them, and many of these people have a low risk, we'll say, for actually having hypoglycememia. At what point do you decide to admit these patients to do a 72-hour fast versus sometimes we'll bring them in for an abbreviated fast in our diagnostic unit? Do you have any guidance for us as to what your practice is?
Absolutely. Well, again, it's a clinical decision. I don't think there is a standard. But those patients that are kind of shorter duration, right, associated with some kind of more or less newer onset weight gain. And obviously you still want to see, and nowadays we still use the CGM and I ask patients to turn off the alarm, just keep a tracer, keep a blood sugar log. So if I have my much lower probability value, and if I want to exclude things, then a lot of times mixed meal test is a good tool to kind of give a reassurance to the patient and kind of navigate them a little bit more towards dietary changes. I was not a big fan of mixed meal test because I thought it's an old school, who does it? But, I found it helpful. And so I thought to share. Obviously, someone who has more severe hypoglycemia, and you kind of worry about things and you lose your sleep over it. Again, shorter duration, more severe weight gain, no other risk factors. Or sometimes you just have to admit those patients, okay? and you have to rule it out because it's a liability if you miss those. But honestly, I have not seen a lot of insulinoma patients, but everyone that I have seen, those patients were presented from the emergency room. I've seen someone else's insulinoma workup being worked out, but I don't even know. So most of the 72 hours fast admissions are more for rule out. So the truly insulinoma usually presents more acutely in a little bit different scenario. That's kind of my experience.
Great, thanks.
Dr. Raff, you want to unmute?
Yeah, so I've followed this story for many years, and I'm not an expert. Let me just start with that. But there's always this talk about pathological histological changes to the islets, and is that just all a myth, or if perchance you could actually look at a slice through the pancreas in these post-bariatric patients, would there be changes to the islet cell histology?
Right. I mean, I'm sure there was a period of time in of the necidioblastosis, right, when they blamed this beta cells hyperplasia that would result in hyperinsulinism and hypoglycemia, and those patients that had, I mean, obviously there are several patients who did end up getting some kind of partial pancreatectomy. They have not done well, and it did not resolve in a resolution of hypoglycemia. So that's how the surgical approach for the necidioblastosis kind of being abandoned. And I don't think I ever seen patient getting surgery for that particular matter. I'm not aware of any changes in reduced maybe glucagon alpha cells. I mean, you can speculate. I don't think I came across any study that would demonstrate any kind of islet cells changes associated with hypoglycemia, but that would be interesting venue to further study.
Yeah, because now, of course, there are animal models of bariatric surgery. So stuff you couldn't do in your patients, you could certainly do in those models. But thank you very much, because, when you hear students talk about it, which is what I teach, they conflate these various histological, pathological findings with physiological hypoglycemia, which is essentially what you're talking about. So thank you very much.
Absolutely. Thank you.
Thank you. Any other questions? I don't see anyone's hands raised, and there's nothing in the chat box. So thank you so much for giving us this lecture, and I definitely learned a lot. And we look forward to seeing you next week.
Well, thank you, Dr. Kidambe. It's been a pleasure, and I learned myself a lot of things just getting ready for this presentation. And it's been great. Yeah, thank you very much for having me.
Thank you. Bye.
Bye.
Good evening, everyone.